Thanks to Dr. Guha for this wonderful opportunity. Coming straight to my talk, the indication for colorectal biopsies has not really changed for a long time. Infectious, uncontrolled, relentless uveitis involving the retina and the choroid remains an indication apart from the tumors involving the retina and the choroid, where the clinical picture is not classic. What we say is they masquerade actually. Only found that which has happened in the last 1 decade is people are using it more and more for CRBs in case of uveal melanomas because they want to treat of uveal melanoma before they do 1973. The there are a lot of changes since then, last 5 decades. He started with ab externo approach, that is transscleral, which is still relevant in present time and still can be used for anterior large tumors. So by making a partial lamellar scleral flap, as we do in filtration surgeries, the inner flap and the tumor segment is taken as a biopsy. And once the diagnosis is made, then this area and the tumor has to be appropriately treated. So it was a difficult procedure for the posterior tumor, so it gave way to the other ab interno techniques. And first came this full thickness biopsy, which became popular first, especially when both retina and the choroid were involved. Later, now there have been they have been done for the eye, the tumor size is small, or where the transvitreal biopsy has failed. But in cases where retina and choroid are both involved in uveitic conditions, still it is being advocated. So what is important is instrumentation, because the large gauge instruments are still relevant here, area of biopsy, hemostasis, and these are the things which we have to plan while we are trying to take a large colorectal full thickness biopsy in these patients. The area, the side, are very important actually. So this is one of our patients where we treated this patient, was treated with Ozurdex and infectious uveitis, worsened, came out to be toxo-positive, we treated with toxo treatment, but he showed initial improvement, later worsened actually to the extent that he had vasculitis which bled, and we went for surgery and we removed these sheets of blood, and inside we still found the retinitis which has increased more. So we thought that better to take biopsy in this patient because patient is kind of locally immunocompromised because this was Ozurdex was given. This is how the side of 2 by 2 mm is prepared. Normal retina and the abnormal retinal part is taken. You can do pottery also. I prefer laser. So you want a 4th port, large 20G, because you want to insert a 20G vertical scissor to carry out this dissection, which is done inside the plane of the laser. Once you see a whiteness of the sclera, you know you are in the right plane. Then you just have to feel the toughness of sclera and keep cutting with the vertical scissor. Some bleeding will occur, but you have to take care with the bottle height. Retina and the choroid sometimes separate from each other. You have to make sure that the vitreous has been completely removed so that it doesn't happen. Once they are separated, you have to take it out with the appropriate forceps through a large wound, and then it is sent for the handled for the sampling and for the preservation, as done in this patient. So as we are moving towards the minimalistic approach to avoid the complication of bigger gauges, this has happened here also in the retinal choroidal biopsies. Biopsies with the smaller gauge cutters were introduced, and this completely replaced the needle biopsy, where the yield was poor. So it was useful. It was shown that it was useful for the tumors more than 3 millimeter. And vitrectomy, no vitrectomy, these are the two techniques you use. Dr. Prithvi, he is a good friend. He says that it works in tumors, 0.8 mm tumors also. The catch here is more is the bigger is the tumor height, more is the yield, more are the chances of picking up the diagnosis. These are few tips he says no full vitrectomy, high VAC, low cut rate, and you have to cryo the wound sites and treat the patient appropriately in this no PPV transmitted technique. Other technique which we use very commonly in our uveitis patients and in our lymphoma patients, that is we do PPV along with it because we tend to take vitreous biopsy also. So in this patient, like you see, this patient is again the relentless progressive retinitis happening in the both eyes. We went ahead to take the subretinal biopsy and the vitreous biopsy. You will see that we do not use the saline first in the eye. We make sure that we take the undiluted vitreous sample, and it is taken with the help of an assistant and under very low VAC and very low cut rate to avoid the damage to the cells. And this is all underdone in the air. You can yield around 2 to 2.5 ml of vitreous with this technique. Once the adequate vitrectomy has been done, then you have to, as I showed that I wanted biopsy also here. So with the laser, I made a retinotomy, and then with just the passive aspiration, active aspiration held by the assistant, I took out this fluid from here. You will see that we have used this syringe there, and this technique is it can be used with the MIOCT because we are exactly able to see that whether we are able to pick out the cells, get the cells into the silicon tip of the aspiration needle or not. You see that MIOCT has been used in this case. We can appreciate the movement of the cells within the silicon tip cannula, making sure that what we have achieved, what we have gone inside the eye for. So in the end, when we come to the diagnostics and complications, they vary from pathologist to pathologist, surgeon to surgeon. But we have to remember, we have to work as a team. Once we are planning to tread into these fields, that we have to make a team which will consist of a cytopathologist, histopathologist, and cytogeneticist, because teamwork is going to be the key in colorectal biopsies. Thank you so much once again, Dr. Guga and AOS. Thank you so much.